I'm one of the anesthesiology faculty at the University of Maryland Medical Center in Baltimore, Maryland. Today, I'll be discussing about perioperative pain management option for cesarean section. Here's my contact information. So, objective for our today's presentation is first I'll be discussing about Erector opioid, mainly focusing on intrathecal morphine, and I will discuss about potential analgesic benefits and adverse effects of the intrathecal morphine. And given the recent emphasis of multimodal analgesic approach for the pain control after surgery, I'll be discussing about non-opioid analgesic option for cesarean section. And finally, I will be briefly going over peripheral nerve blocks and their benefit and how to perform those blocks. So why do we care so much about pain control after cesarean section? So cesarean section is a commonly performed surgery, and it is a common source of first exposure to opioids in women. Adequate post-op pain management has been proved to result in early ambulation, a shorter hospital stay, and greater satisfaction of patient. The plan for analgesia after C-section must facilitate bonding between the mother and her newborn and allow safe breastfeeding. In fact, inadequate postpartum pain control after cesarean delivery is a strong predictor for developing chronic pain later. Then let's move on to neuroxial opioid. Intrathecal morphine is considered the gold standard for analgesia after cesarean delivery. Neuroxial morphine provides analgesia for up to about 24 hours. Compared with systemic opioid, Erector opioids are associated with improved patient satisfaction, lower pain scores, and increased time to first request of rescue analgesia. Compared with systemic opioid, it allows decreased opioid exposure to a breastfeeding neonate. However, it is not without potential adverse effects. These are the potential adverse effect of intrathecal morphine. Every time we administer Erector morphine, we need to be concerned about potential respiratory depression. Respiratory depression has a biphasic pattern with the initial onset within the first 1 to 3 hours and late onset at about 6 to 12 hours after administration. Other side effects are nausea and or vomiting, pruritus, urine retention. As you can see, relative risk is higher for the intrathecal morphine group, and especially when you administer intrathecal morphine, the local anesthetic for your spinal dose, bradycardia is much more common. And herpes simplex reactivation is one of the known complications with the Erector opioid use. Therefore, you need to discuss the patient if patient has history of herpes lesion before. Now, what about route? Intrathecal versus epidural route, which one is better? So in our institution, we tend to use combined spinal epidural anesthesia for the because complexity of the patient. Intrathecal morphine and epidural morphine both routes are absolutely available for our institution. Then which one's better? So then there's one study looking at the quality of analgesia and instance of side effect of intrathecal morphine versus epidural morphine. Pretty much they are similar. Typical dose of intrathecal morphine at a dose of 100 to 200 microgram. Epidural morphine dose 2 to 3 milligram. So theoretically, mom actually got higher exposure to the morphine. If you got epidural versus intrathecal morphine, but still pretty small amount. Interestingly, pruritus can be more common in intrathecal morphine, and onset is obviously faster for the intrathecal morphine over the epidural. And these are the typical dose we can utilize for the C-section for the intrathecal morphine dose. So, obviously there is 3 categories. You can categorize intrathecal morphine dose, to ultra low dose, if less or equal to 15 microgram. between 50 to 150 microgram is low dose. If you higher than 150 microgram, you consider as the high dose. Based on the dose, respiratory monitoring after surgery can be a little different. If you choose to give higher dose, then you need to continue to continue respiratory monitoring every hour up to 12 hours, and every 2 hours after that, another 12 hours. If you use ultra low group, SOAP indicate that there is no additional respiratory monitoring required. That being said, if patient has history of high BMI over 40 or severe OSA or other comorbidity, then you probably still need to carefully monitor this patient for potential respiratory depression. And then why somebody decide to use high dose versus ultra low dose? I think depends on what you're looking for. If you're looking for better pain relief, then probably higher dose, probably 150 to 200 is better than ultra low dose. But if you're really concerned for potential complications such as nausea, vomiting, then probably ultra low dose probably will be better over a high dose. Then what about intrathecal morphine versus hydromorphin? Given our pandemic, there's a recent shortage of various medication, especially for the narcotic. Then, as you all know, morphine is more hydrophilic than hydromorphin, therefore increased cranial spread, greater dermatomal analgesia, and longer duration of the action were anticipated. But there's one study actually looking at, and they found there's no significant difference between 150 micromorphine versus 75 microgram of hydromorphin in median pain score in 24 hours, and opioid consumption, and the incidence of side effects. And interestingly, the median time to first opioid request was 5.4 hours for hydromorphin and 12.1 hour for morphine. So morphine actually is better in terms of first opioid request, but otherwise there's pretty much no difference in terms of 24 hours outcome. Then let's move on to non-opioid analgesic options. Let's talk about acetaminophen first. Acetaminophen has been widely used for post-op pain control for various surgery. Although the exact mechanism of action is still unknown. And actually, a lot of studies looking at the possible mechanism of action, they indicate that selective COX-2 inhibition can be one of the mechanism of action of acetaminophen. The recommended therapeutic dose for adults is actually 4 grams in 24 hours. Obviously, high dose of acetaminophen can cause hepatotoxicity and renal toxicities. That's the reason why you're trying to limit the amount of dose to 4 grams. Both oral and intravenous form are available in US. So which one is better? Oral versus intravenous acetaminophen. Intravenous acetaminophen has been available for few years now. So everybody was really excited, and they decided to use pretty often for the IV route. In fact, the cost of intravenous acetaminophen is over 100 times higher than oral administration, about $8 for 24 hours versus 80 cents for 24 hours. Then, then we need to consider cost and benefit, right? Then, there is one study looking at intravenous acetaminophen and then, versus oral administration. It did not reduce 24 hours opioid consumption or other outcome compared with the oral acetaminophen. Although intravenous acetaminophen decreased opioid consumption and pain score compared with the no intervention groups. So probably it's reasonable to use the intravenous acetaminophen if patient is strict NPO including MAT. Otherwise it's not indicated in our patient population. What about NSAID? NSAID has been shown to reduce pain and opioid consumption. It is routinely administered for 48 hours after cesarean section. IV ketorolac is efficacious in reducing post-op pain and narcotic use after cesarean section. There is one study looking at 15 milligram versus 30 milligram for the pain control after C-section. They indicate that there is no significant difference between two groups, so it's probably reasonable to start with a smaller amount, as there is no additional benefit. So we all know that NSAID has some possible adverse effect, and NSAID should be avoided in patients with thrombocytopenia or the risk factor for severe bleeding, as non-selective NSAID inhibit platelet function. If there is a concern for postpartum hemorrhage, then probably NSAID will not be the good option for the pain control. Otherwise, NSAID should be always considered for the post-op pain control for the C-section. And in addition, NSAID should be considered carefully for the breastfeeding mother or infant with a ductal-dependent cardiac lesion, because it can theoretically close the duct. Then it can compress circulation for the neonate. What about gabapentin? Gabapentin has been used perioperatively to improve post-op pain and limit opioid requirement. However, recent studies showed its analgesic benefit were clinically insignificant. It is associated with a higher instance of sedation. Therefore, a routine use of gabapentin for cesarean section is not recommended. Gabapentin may be considered for select to the patient with uncontrolled post-op pain or high opioid requirement despite multimodal analgesia. The goal of ENS recovery after C-section is to promote early ambulation, but if patient is too sedated because of gabapentin, then it's going to hinder our goal, especially patient going to have high risk for fall. Then what about schedule versus PRN? The combined use of acetaminophen and NSAID are superior to the use of single agent for the post-op pain reduction. Administration of pain relief analgesia in fixed time interval, which is scheduled after C-section, and showed reduced pain score compared with the on-demand, which is PRN. So it's better to schedule your medication, especially non-opioid medication, for the in order to decrease opioid use post-op period. Then systemic opioid, despite multimodal analgesia in addition to neuraxial opioid, high percentage of patients still require opioid at some point during hospitalization. In one study, approximately 1 in 8 patients require IV opioid after cesarean section. Several studies have reported the benefit of using low dose of oral opioid over higher one, because there is no benefit in terms of pain control. They just have higher side effects secondary to higher opioid use. Let's move our gear a little bit to the peripheral nerve block. Let's talk about transverse abdominal spleen block first. It has been widely used for the abdominal surgery because of simplicity, also superficial nature of the nerve block. As you can see from the side, this is ultrasound image on the side of the 3 muscle groups. One is external oblique, internal oblique, transverse abdominis. The target of the injection is between internal oblique muscle and transverse abdominis muscle. So pretty much you're trying to block the spinal nerve and ilioinguinal, also hypogastric nerve for the pain control for the C-section. So because the nerve coming from the lateral to medial direction, you want to perform your block more laterally in order to catch all this nerve before they spread out. You can perform this block under, based on anatomical approach too. Pretty much you need to feel superior, inferior, and lateral and medial border of the each group. Pretty much subcostal margin will be your superior border. Iliac crest will be the inferior border. Latissimus dorsi will be posterior border, and anterior border will be the external oblique. This small triangle called as triangle fatigue. Pretty much, if you can feel all this structure, you can potentially, perform this block, with anatomical approach. However, because the patient population usually, it's really hard to fill this spot. Probably it's better to use ultrasound because you can actually visualize your needle, you can inject your medication into the exact location, and you can avoid the potential complications such as bowel perforation or injecting local anesthetic into the vasculature. Then what's the outcome of the transfer abdominis plane block? TAP block has been associated with less pain within 12 hours of C-section, a low opioid requirement after surgery. However, the most recent meta-analysis indicate that TAP block does not provide additional analgesic benefit in the setting of intrathecal morphine administration. I was a little bit disappointed about this finding, but at the same time, TAP block still can be reasonably used for the patient who need to have C-section under general anesthesia because of emergent condition or because of there's contraindication for the reduction anesthesia. Then TAP block can be reasonably used for this patient for the better pain contracted surgery. Also, patient has a severe history of post-op nausea vomiting, especially secondary to opioid. Then TAP block can be actually a really great option for the patient population. Then let's move on to different block. So quadriceps lumborum block has been widely used for the abdomen surgery as well. The benefit using this quadriceps lumborum block, so-called QF block over TAP block, because there's a potential local anesthetic spread into paravertebral space. It can provide both somatic and visual pain control. There's 4 different locations of the potential induction for the QL block. So based on the location, you can number the QL block as 1, 2, 3, 4. So if you're injecting medication lateral to quadriceps lumborum muscle, then called as quadriceps lumborum 1. If you inject the medication posterior to QL muscle, then called as QL2. If you inject the medication anterior to QL muscle between the psoas and the QL, then they're called as the QL number 3. And if you're injecting medication into the QL muscle by itself, then they're called as a QL4. This is ultrasound image on the side. Because it is considered deep block, you probably want to use a curved linear probe. You can identify either from the posterior to anterior or medial to lateral. So the way I'm actually scan my patient, I'm trying to scan the patient from the medial to lateral direction. I'm trying to identify the vertebral body so that I can identify the psoas muscle first, and then usually psoas muscle will be hyper echoic versus a QL, which is a little bit hypoechoic. And then once you find the border, and then you can actually inject the medication in whatever location you're trying to inject, QL1, QL2, QL3, or QL4. Another way to identify QL is from the medial to lateral direction. So pretty much once you find the TAP line, which is intraoblique and the transverse abdominis, you can move your probe to the medial to laterally. You can find the epineurisis of the external oblique and the transverse abdominis muscle. Then usually occurs located in deeper to this epineurisis. So if you inject the medication in this plane, usually you can easily perform QL1. If you can actually identify the QL, then you can advance your needle further to provide to perform the QL2 block. Then what's the analgesic benefit of the QL? Then let's compare TAP versus QL. A posterior QL block resulted in better analgesia and lower opioid consumption at 12, 24, and 48 hours, but not at 4 or 6 hours compared with the TAP block. And meta-analysis also showed quadriceps lumborum block appeared to be superior to pain control in absence of intrathecal morphine compared to TAP block. That being said, there is no obvious benefit of QL block in the setting of intrathecal morphine administration. That being said, the recent study actually showed additional analgesic benefit when combined with the intrathecal morphine. So, we need a little bit more study, and then we need more data to conclude, in order to conclude, there is additional benefit of the cure in the setting of intrathecal morphine. And also another thing I want to point out, QL block can result in lower extremity weakness, especially when you perform the QL3 because you inject local anesthetic between the plane QL and psoas muscle, theoretical lumbar plexus area. Then let's move on to erector spinae plane block. So if you pretty much erector spinae plane block, the location of the injection between erector spinae muscle and transverse process. This is ultrasound imaging of the same picture. Pretty much you use a linear probe to identify the structure here. So pretty much, you inject the local anesthetic into the spine. There's a couple potential mechanisms of erector spinae, although the exact mechanism of action is still unknown. So first, there is a potential spread of local anesthetic into the paravertebral space that can provide somatic and visceral pain control, or local anesthetic in a system absorption can also cause some pain control for this patient. So compared with the TAP block, the ESP block provide more effective pain relief, has a longer duration of analgesic action, prolonged time to first analgesic requirement, and less opioid use in terms of consumption. Opioid consumption was lower, and time to first request for this analgesia was longer in the ESP group, even compared with the intrathecal morphine. But we need more study, more data to conclude this, the statement. So in summary, erectional morphine is considered the gold standard for analgesia after C-section. Multimodal analgesia has proven its effectiveness in post-op pain control after C-section. It can reduce use of opioid and their associated adverse effects. A multimodal analgesia should include scheduled NSAID and acetaminophen. Low dose of systemic opioid should be only reserved for severe breakthrough pain, and various peripheral nerve block demonstrate potential analgesic benefit after C-section. However, additional analgesic benefit are still unclear in the setting of intrathecal morphine administration. And here are references my presentation, and thank you so much for attention. Please feel free to email me for any question. And once again, thank you so much. Have a nice one.
I have done the pain fellowship in London in 2002, and every single job of mine has entailed sessions in chronic pain as well as obstetric anesthesia. I worked in Pure Women's and Children's Hospital in Singapore and Qatar in Doha in Sidra Medicine. And I was one of the members to have activated the chronic pain clinic in Sidra Medicine. And I'm proud to mention that that is the first and the only pain clinic exclusively for women, let alone in Doha or Qatar. It's in the entire Middle East. I'm going to talk about chronic pain in pregnancy, something which we all come across, but at the same time, we find that the women women, when they become pregnant, they actually become more tolerant to pain in a way. That's not true, but they suffer in pain. And in general, the dictum or the culture is not to have much of the pain relief or not to do much about the pain, which is wrong. I mean, nobody should suffer in chronic pain, let alone the pregnant woman. So when you consider the prevalence of pain during childbearing age, you find the topmost three, which the three painful conditions are migrainous headache, and back pain and neck pain, and the risk factors which are on the rise are obesity, sedentary lifestyle, and this data is not pertinent to US alone, but also Australian data supports the same. Common chronic pain conditions in women are migrainous headache, fibromyalgia, back pain, pelvic pain, and rheumatoid arthritis. Now we know that many autoimmune diseases, they improve on their own during pregnancy, and same is true with migraine and rheumatoid arthritis. But when it comes to back pain and pelvic girdle pain, that's not so. They actually worsen as a direct result of pregnancy. There are some chronic pain presentations we come across when the women are pregnant. They are either referred to in the pain clinic or the women directly come to see you. They are lumbar disc prolapse, herpes zoster, radiculopathy, and trigeminal neuralgia. If you see the table, quite often you will find that lumbar, lower back pain, hip pain, pelvic girdle pain, feet pain top the the painful conditions. Now, what are the factors associated with development of chronic pain after pregnancy? We have divided into intrinsic patient factors and extrinsic patient factors. Now, any pre-existing chronic pain and also in the immediate postpartum period lasting up to 2 to 3 weeks is the strongest predictor of the patient will suffer with the chronic pain afterwards. Also same true with the women who did not have previous pain but had pain in the postpartum immediately and for 3 weeks. The possible reasons could be that there is a more extreme response to the tissue trauma of the delivery, or something called as a kindling response, that is the experience of extreme pain makes one more sensitive to subsequent stimuli, just like what we call as neuronal wind-up in the pain clinics, which means that if you get more sensitive, then the nerves learn that pain and the area becomes wider and wider. If the women expect that they are going to have more pain, actually they have a better pain relief. I need not stress upon the fact about anxiety and depression. They are directly related to the experience of the pain, and there is some genetic variability, especially including the COMT catecholamine O methyltransferase gene that regulates the response to catecholamines. This finding is supported by the fact that there will be rise in blood pressure, which strongly correlates with the postpartum pain. And there are extrinsic or environmental factors, what we call sleep deprivation and stress for the major ones. Women who did not sleep for 6.5 hours a day suffered with more pain. And it's actually a vicious circle. You have pain, you don't sleep well. And that's a vicious circle you form, you have more pain. The intraoperative factors like closure of peritoneum, there was a good study which in a way showed that if they closed the parietal peritoneum, the women had more chronic pain. What about aggressive treatment of pain during pregnancy? Does it change? Does it alter the progression to chronicity? Probably yes. So especially we know for the fact that epidural morphine reduces development of chronic painful conditions. Now, let us talk about management of chronic pain, which is so important. It has to be multimodal. It's called as balanced analgesia. The main rationale is that we should have the medications which work as additive or synergistically, like NSAIDs and opioids. What we know about opioids and NSAIDs is that if we combine them together, they don't individually, they don't work as to one. They actually add up and give the benefit as more than one, that is more than two, rather 1 + 1 is more than 2. That is called a synergistic effect, and that's what exactly happens with opioids and NSAIDs. The main goal is to give the maximum analgesia with minimal side effects to both mother and the baby. One has to consider the important fact that lactational mothers, they are going to transfer whatever they take, like medications also into the breast milk. And in general, the medications with infant plasma concentration of less than 10% are considered safe. So at the outset, what are not safe? Well, citalopram, fluoxetine, diazepam, the concentration is more than 10%. There are 3 limbs of management of chronic pain. One is non-pharmacological, pharmacological, and interventional. Let us go one by one. So, non-pharmacological form of pain management, it's exclusively used in pregnancy and quite often some chronic pain conditions, especially physiotherapy, mindfulness, psychological support, TENS machine treatment, acupressure, acupuncture, and massage. I have myself managed one patient of rheumatoid arthritis throughout the pregnancy with plain acupuncture. Yes, she needed to come quite often, but it worked her miracles. I'm not claiming by any means that acupuncture works in everyone. It's just my experience with one patient. And I remember that because she was related to royal family. The problem with the medications is that if we give them too early, then during pregnancy, then there could be a risk of structural teratogenicity or even the embryonic loss. And if we administer them late during pregnancy, there is a risk of behavioral teratogenicity or preterm labor. And if we give them after delivery, during lactation, then there is a risk to neonate an infant by the breast milk. Now, there's an important website you may want to note called as LactMaid. It gives the information and impact of individual medications on breastfeeding. The main medications we use in chronic pain clinic are NSAIDs, selective and non-selective COX-2 inhibitors, paracetamol, gabapentin, pregabalin, antidepressants like TCA and tricyclic antidepressants and SSRIs, selective serotonergic reuptake inhibitors, and opioids. In general, NSAIDs are considered safe, but is it so? Well, ibuprofen is available over-the-counter medication, but AICOG warned against the use of ibuprofen in preeclampsia with postpartum hypertension, although this has been challenged in the recent data. But it is better to avoid it in the first trimester because there is a small rise in congenital defect, including the cardiac septal defects and probably gastroschisis. Paracetamol is much safer as compared to other NSAIDs, including during lactation as well as in postpartum. Now, low-dose aspirin, which is given quite often as prophylaxis in preeclampsia, is considered to be quite safe, and to date there are no significant adverse fetal effects. Ketorolac is quite safe as well. The only NSAID I would like you to note is diflunisal. It was associated with cataracts and fatality reported in neonatal animals. So probably I won't use it. About the selective COX-2 inhibitors, those who are interested in tennis will remember that in 2005, the whole US tennis tournament was, US Open was sponsored by Vioxx, that was rofecoxib. It had come in the market just a couple of months before that. But with the concerns of thrombotic and cardiovascular events, it went out of the market within no time. And the loss the company bore was as good as closing the British Airways. So there are concerns about thrombotic and cardiovascular effects with any selective COX-2 inhibitors, let alone Vioxx. The ones which are available these days are celecoxib and etoricoxib. The celecoxib was related to preterm delivery, although it is quite safe during breastfeeding. Paracetamol is considered quite safe. Having said that, there is some recent evidence which found association of paracetamol with attention deficit disorder, autism, or asthma in children. Obviously, we need more studies to confirm this. But otherwise, in general, it's considered quite safe and is most of the time the first line during multimodal analgesia. Gabapentin is another medication which is used quite often during in chronic pain. It readily crosses the placental barrier, but is rapidly metabolized by newborn. Gabapentin has been used as a pre-medication for cesarean section 2. In general, there were no maternal side effects, neither fetal side effects in the gabapentin pregnancy registry. The pregabalin, which is other anticonvulsant, falls in the same class of gabapentin, has not been well studied in pregnancy, but in general, there is no reason to consider that it is as safe as gabapentin. Tricyclic antidepressants and SSRIs form the main antidepressant class. In general, Swedish registry found a possible link with the exposure of tricyclic antidepressant with congenital malformation. Amitriptyline and nortriptyline have been studied the maximum. The most epidemiological studies show no major risk of congenital abnormalities. And when it comes to using them during pregnancy, the global IQ scores and neuropsychiatric disorders were not that much implicated. It's not secreted much in milk, so that way it is not too bad to have. Fluoxetine and duloxetine have been also studied quite extensively. Duloxetine is used in fibromyalgia. It is actually licensed to use in fibromyalgia. There is some evidence of development of persistent pulmonary hypertension of newborn in preeclampsia. Opioids, very important class of medication, and obviously fear of using opioids because of becoming dependent. But the risk of progressing to become a chronic opioid user because of newly persistent pain is very likely to be very low, very low. So you don't find opioid addicts when you start opioid medication for a newly diagnosed chronic pain. And any studies, when you look at them, they will have confounding factors like concomitant use of alcohol or tobacco or other substances and illicit drugs. Having said that, there is a risk of miscarriage with opioids. There are also congenital defects like ASD, VSD, cleft lip, cleft palate, neural defects, clubfoot, including tramadol was associated with cardiac defects and clubfoot. So in general, I would say that it's not a good idea to use opioids on a long-term basis in pregnant women. Other condition which I mentioned to you initially was migraine, which is not uncommon in women and in pregnant women. Having said that, as mentioned earlier, during pregnancy, the incidence of migraine actually gets better. Having said that, we do come across patients with migraine quite often in the pain clinic, referred mainly by obstetricians. There are a few medications which are used for migraine quite often. One of them are triptans. There are 7 available triptans. Sumatriptan has been studied the most. They are considered quite safe. There are no congenital malformations, any of the studies they found. I would be quite happy to use sumatriptan, and there are some studies for PDPH as well, the use of sumatriptan for PDPH. Argot alkaloids are generally contraindicated during pregnancy because of uterine artery vasoconstriction, and there have been reports of syringomyelia and renal agenesis. So I don't think it's a good idea to use them. Beta blockers are quite safe, but calcium channel blockers, there was probably an association with preterm labor. Don't use valproic acid or topiramate because they are considered teratogenic, and there was association with quite major congenital abnormalities. So I would use them exclusively only if everything else has failed. NMDA antagonists quite good in general. Both are magnesium and ketamine. We have used them during anesthesia practice as well. So ketamine is reasonable to consider in the patients with pre-existing chronic pain because it might prevent the conversion to chronic pain after delivery, after postpartum. Most commonly used is ketamine, and we all are well versed with it. The dose is around 0.25 milligrams per kilogram to 0.4 milligrams per kilogram. We give it intravenously during the intraoperative and immediate postoperative period. Magnesium we have used for as management of preeclampsia, but there have been some studies which looked at neuraxyl magnesium. But we need to have more studies to evaluate the neurological complications associated with magnesium. Alpha-2 blockers, again, we use clonidine intraepidurally, or some use intrathecally also. There is a black box warning. It is not recommended for postpartum or perioperative pain management because of the significant impacts of bradycardia and hypotension. However, in rare obstetrical perioperative or postpartum patients, if the potential benefit outweighs the risks, then we should use it. Now, what about the interventional management? With the advent of ultrasound and with the use of minimal use of fluoroscopy, I will definitely look at interventional management as one of the main lines of treatment when it comes to managing the chronic pain during pregnancy or in immediate postoperative period or immediate postpartum period. We used to say no to radiation, and that's true. But at the same time, with the advent of ultrasound, which is one of the friends we have in anesthesia when it comes to regional anesthesia, I have used interventional management very often in chronic pain to treat the chronic pain in pregnant women. We worry about corticosteroids. Are steroids safe? Well, I would say they are safe because there are data to support it. A very good study which supported corticosteroid injection in orthopedic complaint in a female with gestational diabetes even. And the dose of steroid which we use in chronic pain is so minimal, around 40 to 80 milligram, which is really not much of consequences. The commonest interventions we undertake in the chronic pain clinic, rather they are usually done in the chronic pain clinic or in the operating theater, like fascicle blocks or epidural injections, or dorsal nerve root ganglion blocks, which are called as nerve root blocks, occipital nerve block for migraine and headaches. They actually work quite well, and most important is that they will reduce the requirement of analgesics or medications, which may be required to take, which may be required to be taken for a long time. So with the blocks, they work for 3 months to 6 months, maybe a year, and sometimes they work for longer. And quite often you can repeat them. And I'm not saying that once you do the block, you do the blocks for entire life. You don't require to do that. One more important factor to remember these days is that we may come across patients with spinal cord stimulators. They are usually placed quite high. We normally place the epidural at L3, L4, or L4, L5. The spinal cord stimulators are placed mainly in the lower thoracic region. But important to remember that we may come across patients with spinal cord stimulators, so have a bit of a thought about it. I would like to thank all of you to have been patient to listen to this talk, and I really thank you. And Ganpati Bappa Moria, any questions, please, I'm quite happy to answer. Please feel free to do that. Thank you very much.
Thank you so much, Dr. Kulkarni, for this excellent lecture. You've gone through all the details about post-operative pain. So shall we